Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Maryland, Virginia Home Improvement Network, exploring clinical strategies for improving wound pain call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Linda Harris. Ms. Harris, the floor is yours.
Thank you, Laura. As Laura mentioned, I am Linda Harris, an improvement consultant with VHQC. On behalf of VHQC, I want to welcome you to the Exploring Clinical Strategies for Improving Wound Pain Management webinar. Before we get started today, I have a few housekeeping items. First, today's session will be recorded, and the recording will be emailed to you and will also be available on VHQC's website within 7 days. We ask that you be present, avoid multitasking, and set your cell and email to the side. Participate in the chat questions or discussion and polling questions. You may access chat by clicking the chat icon in the upper right-hand corner of your screen. And finally, commit to sharing your learning from today's session with your team. We would greatly appreciate your feedback to assist us with future planning. Please take a minute to answer the questions that will appear on the right-hand side of your screen at the end of the presentation. To begin our webinar on wound pain management, we are pleased to have a family caregiver who will share her individual story. Welcome, Carol. Thank you for being with us. You may share your story now.
Good afternoon, everyone. My name is Carol, and among the many other things that I have done in my 73 years, I was a direct caregiver to my father-in-law. 9 years ago, my husband and I brought him to live with us from a nursing home so that we could care for him. My father-in-law was 88 years old, had advanced Alzheimer's disease, and could not walk. He lived with us 7 years, and for about 5.5 of those years, he was bedbound. Before my father-in-law came to live with us, he had developed a pressure ulcer on his left lower back that was the size of a fist. I was the primary caregiver during his time with us and had no experience taking care of pressure ulcers, but I thought that I could. The Veterans Administration provided medicines and dressings that I changed often, and I turned him throughout the night like they told me. The open pressure ulcer eventually closed up and healed completely. I think I did a good job caring for him, but I wish I had known about the pain caused by pressure ulcer. I now remember noticing how he would quietly frown and tighten his face when I changed his dressing. I hope that caregivers like my husband and me can learn more about caring not only for the physical health of their loved ones, but also for their comfort and how to keep them free from pain. Thank you for giving me this opportunity to share my story.
Carol, thank you so much for sharing your personal experience.
Thank you for having me.
You're welcome. At this time, I am pleased to introduce our speaker, Sue Crahan. Sue is the program manager for the VCU Wound Care Team and faculty expert for the Nursing Home Improvement Network. Welcome, Sue.
Thank you. Thank you so much, Linda and Carol. Thank you so much for sharing your story. It's my pleasure to be with you all today to have some discussion around how to manage residents with wound-related pain. The objectives for our webinar today include describing the different types of pain that are experienced by an individual with a wound, discussing the effects of wound pain on quality of life, and then exploring some strategies for managing both procedural and non-procedural wound pain. In healthcare, we often think of our role as one of curing disease and relieving symptoms. And indeed, those things are important, yet they're not always attainable. What is always possible is to provide comfort. In today's webinar, let's explore how to bring comfort to the residents experiencing wound-related pain. First of all, I want to begin with a definition of wound pain. It is described as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So you can see by this definition that it's not only something that our central nervous system responds to in terms of it being sensory, but it's also very much an emotional experience for an individual. And then pain management is defined as the elimination or the control of pain with the goal of restoring comfort, quality of life, and the capacity to function as well as possible, given that individual's circumstances and their source of pain. Pain, when it's experienced, has two different consequences on the individual. It has a physiologic impact, and it has a consequence on the quality of life. When we talk about the physical impact or the physiological impact that wound pain has, it can be described as either nociceptive or neuropathic. Nociceptive pain is actually our body's central nervous system detecting actual tissue damage. When the cells in a wound are damaged, they release chemicals, and those chemicals then trigger nerve fibers to transmit pain impulses along this pain pathway to the spinal cord, and then the spinal cord transmits that information up to the brain where it's centrally processed. Synaptic junctions in the spinal cord and the brain either attenuate or they amplify that pain signal, and thus affect how the intensity of the pain signal will be perceived or interpreted by the individual. So in addition to that actual tissue injury that triggers the episode of pain, known as nociceptive pain, there's also this psychological, emotional, and cultural experience that the patient goes through as well. And those things then define for that individual what their pain experience is. So the same type of injury, the same type of wound in two different individuals often generates a very different pain experience in terms of the quality and the severity and the impact of that pain, because everyone has a different psychological, physical, emotional, and cultural response to that stimulus. So in essence, pain is a very individualized and very personal experience. Neuropathic pain, on the other hand, unlike nociceptive pain, neuropathic pain is not an indication of tissue injury, but rather it's actually an indication that the sensory nerves are malfunctioning. So it's not that they experience pain that travels through the central nervous system to the brain, like nociceptive pain. This is where the nerve fibers are actually already damaged and are malfunctioning. So that pain signal is actually a mixed signal. And neuropathic pain, the origin of it is either visceral or somatic. Visceral neuropathic pain begins in the deep internal organs and the GI tract, and patients that experience this describe their pain as diffuse, gnawing, or cramping. Unlike somatic neuropathic pain, which originates in the bone, the joints, the muscles, the skin, and the connective tissue, which primarily is what is associated with wound pain, neuropathic pain is described by residents as localized, throbbing, and electric shock or burning type pain. In chronic wounds, the pain experience is either cyclical non-cyclical, or persistent. In non-cyclical acute pain, this is described as a single pain episode, like sharp debridement. So it's not something that's necessarily repeated. It's a specific single episode of pain. Non-cyclic pain can be dealt with using pharmacologic agents. Cyclical pain is pain that recurs as a result of repeated treatments, like daily dressing changes. And cyclical pain can be treated with both pharmacologic and non-pharmacologic interventions, and we'll discuss those both later. And then chronic pain is persistent, and it's continuous pain that occurs without the manipulation of the wound. So unlike cyclical and non-cyclical, persistent pain doesn't even require one touching or manipulating the wound. And chronic pain can be dealt with through the intervention of pharmacologic and non-pharmacologic type agents. Wound pain is actually triggered by the elements that can be internal or external to the wound itself. Internally, wound-related triggers may include things like the underlying pathology. When I think about people that have sickle cell disease that end up with ulcerations on their lower extremity, it is that underlying pathology that triggers their wound-related pain. Infection and inflammation can also be wound-related triggers, along with just peri-wound irritation and internal nerve damage. The external procedural-related triggers may include things like debridement or dressing removal, adhesive removal, actually cleansing the wound, the application of compressive dressings, and repositioning the resident. Both triggers begin that pain pathway that we talked about, with either it being nociceptive or neuropathic. Interestingly enough, pain is also linked to increased infection. And how that works is that when you think about an individual that is experiencing wound-related pain, it may impede their ability to have that wound cleansed, dressed, or if needed, debrided. If I'm a resident and I'm in pain, I'm not going to necessarily agree all the time for the nurse coming in and doing that irrigation to the wound and changing my dressing and potentially having the physician or the nurse practitioner come by and do debridement. So my engagement in that wound treatment may impact infection because I'm not going to allow those things to occur. Pain also, when experienced, increases the circulating catecholamine and epinephrine level in our bloodstream. And when both of these elements are elevated, it leads to vasoconstriction. So my blood vessels are going to be constricted. And with blood vessels being constricted, I'm going to get a decreased amount of oxygen that makes its way to the wound. Leukocytes is the cell that actually kills bacteria. And without oxygen, leukocytes don't function properly. So I don't have the killing mechanism within my wound to rid my wound of bacteria, and therefore bacteria thrive, creating wound infection. So you can see how pain then is potentially linked to residents having increased infection in their wound. Pain also can trigger a decrease in the amount of granulation tissue that's formed in a wound. And that happens because hypoxic wounds, or wounds that lack a good amount of oxygen, also disrupts the fibroblast. And if you'll recall, the fibroblast is the key cell that's responsible for building granulation tissue because it increases the amount of collagen that's available in the wound. And so when you have a hypoxic situation, you don't have good blood flow and you have a decreased amount of collagen, so also a decreased amount of granulation tissue. So these are just some of the basic negative physiologic effects that pain has on wound healing. Let's look at how pain affects the quality of life. And I also want to make a few comments about the impact of stress on wound healing. So pain, researchers have concluded that wound-related pain adversely affects the quality of life, and the manifestation of this adversity has been reported in a variety of ways. Residents have reported a lack of sleep, fatigue, anxiety, and depression, fear of future pain, which is known as nocebo, the nocebo effect. Pain also increases caregiver burden, because if somebody has a wound with pain associated with it, the caregiver, it requires extra time on the caregiver's behalf to take care of that wound. Residents also report that complaining of pain affects their role and relationship with caregivers. Pain limits an individual's mobility and reduces, therefore, their social activities, which increases their isolation and decreases their self-esteem. One of residents' biggest fears is that of uncontrolled pain. The fear that they're complaining will fall on deaf ears and the pain medication will not be given or will not be given at the appropriate time. And as members of the interprofessional team, we must commit to finding a solution for pain once we know that it's being experienced. It's no longer okay to just say things like, "It's okay, hang on, I'm almost done." We really need to be intervening on a much more productive way. Stress is another factor that weighs heavily when discussing pain and pain associated with wounds. Stress is not an event itself, but it's the perception of an event, and it's actually defined as the consequence of the failure of our human body to respond appropriately to an emotional or a physical threat. So when we have some sort of emotional or physical threat that we don't respond appropriately to, we feel and sense stress. One author actually breaks down the consequences of stress into 4 categories. Stress can be manifested physically, psychologically, emotionally, and through our behaviors. Let's take a look at these for a minute. Someone dealing with stress may experience headaches, have a poor immunity, which then leads to frequent infection. They have tension or taut muscles or muscular twitching. They feel fatigue, can have skin irritation or rashes, and actually experience breathlessness. In terms of a psychological impact, they worry, their thinking becomes muddled, they may have impaired judgment, can experience nightmares, make hasty decisions or be indecisive, and just have a general attitude of negativity. Emotionally, stress induces a loss of confidence. We become irritable, depressed, apathetic, feel alienated, and apprehensive. And it could actually manifest itself in our behavior by being accident-prone, having a loss of appetite, a loss of sex drive, drinking more, smoking more, sleeping less, and feeling restless. And additionally, I just want to throw out this other thought for us to consider, because not only can our residents feel stressed, but let's consider our staff, our employees who come to work stressed. We just read through some of the consequences of stress. So if our employees are also stressed, they'll exhibit some combination of these elements as well. And their ability then to deliver sensitive care and help alleviate the pain and the suffering of our residents will also be affected. And this leads to another major topic of creating healthy work environments, which is a discussion for another day. But my point is that pain management for our residents is multidimensional and doesn't happen in an isolated event within a vacuum. It's complex human beings caring for complex human beings. Just as we talked about how pain impairs wound healing, stress also has been proven to have a negative impact on wound healing. Stress increases cortisol levels. And when you have elevated cortisol levels, you have increased heart rate, increased blood pressure. It affects our immunity. It affects the normal inflammatory response that's necessary for wound healing. It actually delays that whole process of the inflammatory response. Elevated cortisol levels also reduce what's known as cytokines and enzymes. Both these are chemical signals that go on within a wound that trigger the process of the phases of wound healing. And when you don't have that chemical signaling going on within a wound, you actually have a delay in wound healing. Elevated cortisols also inhibit endothelial cells, and endothelial cells are the cells that are necessary for the creation of new blood vessels and also play a huge part in the creation of granulation tissue. So as cortisol levels are increased, the speed of healing is actually decreased. So when you look at stress plus the anticipation of pain, it actually, the combination of those two actually increases the intensity of the pain that's actually experienced. So if we have mechanisms to reduce stress and help residents cope with this anticipation of dressing changes or a procedure, that actually will reduce the intensity of what they experience. Interestingly enough, there were two research that I just want to point out to everyone related to stress and wound healing. This first study by Wyman, Ebrecht, and Scott, published in 2008, actually looked at wounded soldiers. They randomized people into two different groups having the same wound types. And the first group, they asked these soldiers to disclose and talk about and write about traumatic and hurtful situations that they encountered. The second group, that also had the similar types of wounds, they asked them to write about and talk about their time management skills. Well, it turns out that people in the first group, their healing rate was much faster, and this was related to the fact that they were given the opportunity for emotional disclosure. This actually implies that stress management during the wound healing process is effective in reducing wound healing time. There was another study that the same group did where they looked at a group of two different groups. One group was a group of caregivers of Alzheimer's patients, and these caregivers actually had lower extremity wounds. And then the second group was people that had lower extremity wounds that were not in a caregiver role. And those in the second group that were not in a caregiver role, which can be deemed as stressful, healed twice as fast as those that were in the caregiver role that had lower extremity wounds. The second study by Jones, Barr, Robinson, and Carlisle actually concluded that the symptoms that are associated with stress were wound pain and malodor in chronic wounds. So people that had chronic wounds expressed that their most stressful part of having that chronic wound was the pain and the odor associated with that wound. And their stress came out in the form of anxiety and depression. These researchers then treated the anxiety and the depression, and it actually enhanced their time to healing. So, refocusing our assessment on not only developing an excellent plan of care for the wound itself, but also managing people's anxiety and depression associated with having chronic wounds can improve their time to healing. But how do we know if wounded residents are really in pain? Self-reporting is actually the most reliable indicator of the existence and the intensity of pain. But before we talk about a few of these, I'd also just like to mention that there's no direct relationship between the wound appearance, that is, how deep the wound is or how shallow it is or how big it is or how small it is. There's no direct relationship between the wound appearance and the intensity of pain. Consequently, assessment of pain based on wound depth or appearance is not appropriate and is actually flawed. In general, though, wounds do become less painful as they begin to actively heal, but nonetheless, pain is present if the resident indicates that it is, and we must intervene. Intensity of pain scales range from simple to complex, and here's a simple descriptive pain intensity scale where we use terminology that ranges from no pain at all to the worst possible pain, with statements like having mild, moderate, severe, or very severe pain being the increments of intensity. Another self-reporting scale is the numeric intensity scale, where based on a scale of 1 to 10, based on a scale of 0 to 10, with 0 being no pain and 10 being the worst possible pain, we ask the resident how would they rate their pain. And finally, we have the visual analog scale, which is useful in clinical practice for use with residents who are in active pain but don't have the capacity to articulate their pain. These single-item pain intensity scales have all been researched and been proven to be valid and reliable. So what about patients that are cognitively impaired? And nonverbal and cognitively impaired residents are at risk for poor pain management due to the caregiver's lack of pain assessment. It's been stated in the literature that 40 to 60% of residents don't use analgesics and pain relief medication because caregivers may mistake PRN to mean when the resident asks for it. Of course, verbalization of pain or requesting pain meds is unlikely to occur in nonverbal or cognitively impaired residents. They have difficulty finding words to describe their discomfort, or they have an impaired ability to correlate a number on a pain scale with a sensation of pain. This tool that you see in front of you is endorsed by AMDA, and it's the pain assessment in advanced dementia. That's what PAINAD stands for. The items to assess are breathing, negative vocalization, facial expression, body language, and consolability. The total score is from 0 to 10, with a higher score indicating severe pain. So the goal to control pain wound pain is to reduce or eliminate the pain so that the resident can resume and perform their normal activities. And in cognitively impaired residents, the goal is to maximize their comfort and to enhance their quality of life. So let's take a minute here and stop and look at both of these polling questions, and I'd ask you all to go ahead and answer these questions for your facility. Which self-reporting pain intensity scale does your nursing facility use? We just talked about the descriptive pain intensity scale, which goes from no pain to severe pain, using mild, moderate, and severe as the descriptors, or the numeric pain intensity scale, the 0 to 10, or that analog picture scale, or none, or other. So if you could go ahead and click on which one applies to your facility, we'll get those answers. And then the second question that we'd like you to answer is, do you assess pain intensity in your residents with advanced dementia? Yes. A. D. No, but we're considering to do so. And C. No, not at all. All right, so go ahead and click on which one applies to you. And I'm not sure I'm seeing the results here on my end. Okay.
I'm sorry. The results should be up in just a minute.
Okay, very good. Would you like me to move on, or should I wait for the results?
You can go ahead and move on, and then we can cover them at the end.
Oh, that's perfect. Oh, there we go. Okay, I've got the results, so I'll go ahead right now. All right, thank you. So in question number 1, it looks like a majority of the people use the numeric pain intensity scale, followed by the picture, that facial analog scale, and thirdly, the descriptive one. So the answers come in as B, C, and A being the most commonly used ones. And then for our second question, do you use a pain intensity in residents with advanced dementia? I'm happy to say that a majority of the respondents said yes. A handful said no, but they're considering, and a smaller number said also no. So, excellent. All right. Now let's talk about managing wound pain. There are pharmacologic and non-pharmacologic interventions, such as wound cleansing, peri-wound skin, debridement, control of inflammation and edema, positioning, wound dressings, along with some resident-centered interventions that can be utilized. The resident-centered interventions include simply educating the resident about pain and their pain management plan of care. Applying cold or hot, warm compresses to the area surrounding a wound has been found to be comforting and minimize the pain experienced around the wound or with the wound. Massage done by a physical therapist has been helpful. Relaxation techniques or positive imagery techniques and distraction. Using music therapy by actually putting headphones on the resident during the procedure or dressing change can be a helpful adjunctive therapy. Goal setting and aligning the resident's expectation, actually having the resident articulate what they expect to experience is helpful, and demonstrating true empathy and sympathy. Some other non-pharmacologic ideas for minimizing wound pain include how we handle wound cleansing. We want to make sure that we avoid cytotoxic cleansers, which can be harmful and actually hurtful to a resident, but at the same time, we want to make sure that we are doing appropriate wound cleansing, because simply the removal of that excessive debris, especially if it's become dried in the wound bed itself, removing excessive debris and drainage can actually remove tension and pressure from the wound and make the wound feel better. Caring for the peri-wound skin, when it becomes as irritated as you can see in these two pictures, we want to make sure that the interdisciplinary team is investigating the cause of that peri-wound skin irritation and then developing an appropriate plan of care to heal and to heal the area and to minimize reoccurrence of peri-wound skin breakdown. Also, another non-pharmacologic method of minimizing wound pain is actually accomplishing appropriate debridement. And while debridement, I know, may trigger non-cyclical procedural pain like we talked about earlier, debridement also on the flip side may improve wound pain because it's going to, once it's completed, decrease inflammation, tension, and the pressure that's felt with that particular wound that has a lot of necrotic tissue. And I just want to pause for a minute and provide some insight on an up-and-coming new mechanical method of debridement using a microfiber pad. And this new microfiber pad that's on the market allows clinical staff the opportunity to provide effective removal of non-viable tissue. It's actually a 100% knitted monofilament polyester fiber that when you moisten it and you apply it to the wound bed using a circular motion, you're able to dislodge fluff and debris in the wound. The product's been being used in Europe for several years with a lot of success, and just about 6 months ago it was launched in the United States. And how does this fit into the talk? Well, it fits into the talk because this particular debridement technique has been associated with a decrease in verbalized pain associated with debridement. So again, debridement, although it can trigger pain, also overall accomplishing debridement will decrease or minimize pain that's experienced with a necrotic wound. Another non-pharmacologic method is simply edema control. So a lower extremity ulcer, as long as it's been ruled out to not be arterial in nature, many of them that have associated edema will benefit from multi-layer compression wraps. Not only do multi-layer compression wraps aid in healing the wound, but they also aid in decreasing the pain and the discomfort associated with having that lower extremity ulceration. And custom compression hose also falls into the same category. If you're not using a multi-layer compression wrap and simply relying on elevating the extremity to reduce edema, the ideal position for edema control is to have the resident lay back in the bed, flat on their back, with the thighs actually at a 45-degree angle, and then the knee bent another 25 degrees, and pillows contoured to that shape is actually the most productive way to control edema in the lower extremity that has an ulceration. And probably one of the biggest ways that we can intervene with wound pain in a non-pharmacologic manner is selecting appropriate wound dressings. So there are dressings on the market that are atraumatic, that minimize the degree of sensory stimulus to the wound when we're doing dressing change because they're non-adherent to the wound bed themselves. But also, as clinicians, we want to make sure we're avoiding prodding and poking at the wound unnecessarily. Sometimes it's helpful to simply engage the resident and allow them to help or perform their own dressing change. If the resident is verbalizing pain, we need to allow for timeouts, and this helps the resident feel like they have more control over their situation. So if a resident calls for a timeout, we need to honor that and just stop what we're doing, allow them to settle down, allow the stress and the anxiety to kind of minimize itself before we continue with what we're doing. Another hint is maybe just scheduling our dressing changes at a time that the resident would want the dressing to be changed. And I know this isn't always feasible, but there are times of the day that people just feel better and would be more positively engaged in their plan of care if we do it at a time when they feel best. If dressings dry out, we want to make sure that we pre-moisten that dressing using warm solutions before we try to remove them. And if it's a wound that you're packing, you don't need to pack something so tight. Sometimes just aggressive packing or really tight packing induces or inflicts pain in and of itself. So avoid aggressive packing. And if we can use dressings that require less frequent dressing changes because they're more advanced dressings, this will help us to minimize the number of dressing changes. So we can move from that 3 times a day to maybe daily, or we can move from daily dressing changes to once every 3 days or twice a week dressing changes. And this also then will assist in minimizing wound-related pain. Positioning the resident in a position of comfort is also helpful prior to a dressing change. And again, using dressings that are smart, that have that low adhesive or non-adhesive quality about them. Another non-pharmacologic intervention that's out there that I just wanted to highlight is the use of transcutaneous electrical nerve stimulation, or a TENS unit. This is where electrodes are placed at specific sites on the body, depending on where the wound is located, and a current travels through the electrodes into the skin, and it stimulates a specific nerve pathway to produce a tingling or massaging sensation that reduces the perception of pain. And it's a very safe, non-invasive, drug-free method of pain management. And it also helps to offer a better quality of life, especially with people that deal with that persistent chronic pain. So some common uses for TENS treatment right now are, it's frequently used in both acute and chronic pain. It's used around post-op incisions. It's actually used in labor and delivery. It's used for migraines and tension headaches. But also, I just wanted to mention that it's effective in helping to minimize wound pain in certain residents as well. Now, although I'm not a pharmacist, and actually pharmacology is not my strong suit, we can't conclude this webinar without talking about pharmacologic agents that are also helpful. The goal of systemic medication administration as pain control strategy is not necessarily that we're going to be able to stop the pain signal transmission from the wound, but to alter the response of the central nervous system to that pain signal. In the World Health Organization pain clinical ladder approach for the treatment of cancer pain is also used to guide non-malignant pain, such as wound pain. This approach uses a combination of pain control medications based on your assessment of the pain. If pain persists, then the ladder guides the clinician in adding a medication or a combination of medication to effectively control pain. So you start with using what the interdisciplinary team decides to use, but if that pain persists, then you're going to add a non-opioid plus or minus something from that adjuvant medication list. And if after reassessment the pain continues to persist or increase, then you're moving on to opioids, perhaps, for mild to moderate pain. And if you're still not experiencing relief, you move on to opioid medications. So residents with both that nociceptive and neuropathic pain do require a combination of the adjuvant, non-opioids, or opioids until you can actually hit something that works well for them. Around-the-clock medications might be the most effective for continuous, that persistent chronic wound pain. In the pharmacologic area, we also have topical analgesia, which is available. And this comes in the form of jellies, creams, ointments, or patches. Lidocaine and other sodium channel receptor blockers are the primary ingredients in these gels and creams and patches. They usually take, I would say, between 30 and actually 60 minutes to reach optimal effect. These act on the superficial layers of pain receptors, and one topical compound that is frequently used is actually lidocaine 2.5% and prilocaine 2.5%, which comes in an ointment. And this ointment is applied directly to and around the wound prior to doing maybe a debridement or prior to doing a dressing change on someone that has excruciating wound pain. And you apply this ointment, you cover it with an occlusive dressing like Opsite or Tegaderm, and you let it sit for 30 to 60 minutes and then go back and do your procedure. And this has been proven to be a very effective means of caring for that procedural or cyclical type of severe wound pain. So, in conclusion, or in summary, managing pain associated with the presence of a wound not only enhances the cellular and the molecular activity of wound healing, but it also enhances the resident's ability to participate in activities essential to healing. Selected pharmacological agents for the treatment of wound-associated pain should be based on the World Health Organization's recommendations, taking into account pain severity and the type of pain, whether it's nociceptive or neuropathic. And then non-pharmacologic approaches should include the use of atraumatic dressings, educating the resident, empowering the resident, and some stress management in the form of reducing anxiety and depression. So often clinicians have difficulty believing what cannot be directly observed or seen. Healthcare professionals involved in wound treatment tend to focus only on the wound and believe what they can observe. However, we cannot forget that in chronic wound treatment, the resident's pain or stress or depression or anxiety are hidden, and they cannot be observed, but they are as real as what you see. So I thank you for tuning in, and I just want to also make mention of the PDF handout that was sent to you ahead of time, ahead of the webinar. It was an article called The Assessment and the Management of Persistent, Chronic, and Total Wound Pain. And this article, I think, can further enhance your understanding of wound-related pain. It provides 10 strategies for the interdisciplinary healthcare team to consider when you're creating a plan of care for an individual that's experiencing wound pain. And I hope that you will use that to your advantage and as a reference as you continue to deal and manage your residents that are experiencing pain related to their wound. So at this point in time, I'd like to open up our session for anyone that may have a question for us, and we'd be happy to answer that to the best of our ability.
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad. Questions will be taken in the order that they were received, and if at any point your question has been answered, you may press 7 or Q again to disable your request. Please hold for the first question. Our first question comes from Judy Ferguson. Judy, please go ahead.
Hi, my name is Edema. Oftentimes when I'm assessing patients that have diabetic foot ulcers, they say they do not have pain. But when I call the MD, they want me to put pain management. They want me to get pain medicine, give them pain medicine prior to wound care. How do I handle that?
What an excellent question, and what an excellent observation as a clinician. I think number one, I want to applaud the physician for making sure that the resident has pain medication as an option. And number two, though, I guess my thought goes back to, in my reading and in my experience as a clinician, I always think of pain is what the resident or patient says it is. And if people say that they are not experiencing pain, then I would trust that they're not experiencing pain. And if you are not seeing any physical manifestations of stress or anxiety related to the procedure that you're doing, then I think that we can pretty much assume that the individual is not experiencing pain. Diabetics do struggle with neuropathy. We all know that. And one of the pain types that we talked about is neuropathic pain. Neuropathic pain means that the nerve endings are actually damaged, so the signals are not going through correctly. You either don't get any signal at all, which sounds like is the case that you're describing, or you get a mixed pain signal that feels like an electric shock or that burning sensation, whatever. I would say that if a resident verbalizes neuropathic pain, then we should be administering pain meds that are effective for neuropathic pain. If a resident is stating that they are not experiencing pain, then I would not necessarily be inclined to deliver pain medication just assuming that they do have it. And I'd be open to hear from other people that are online about what their perception of this nurse's comments were.
Again, if you do have a question, please press the number 7 or the letter Q on your telephone keypad. Our next question comes from Susan Vega and her group as well. Susan, please go ahead with your question.
CCR, and I just wanted to comment about the last question. What I would want to make sure that we did was really assess that this person is truly not having pain, and do they have any fear of taking narcotics? Is there fear of addiction or fear of drowsiness? Assessing the facial grimacing and anything that we could do to make sure that they truly don't have pain. And then, of course, if we feel that they don't, then we would, again, as our job would prescribe that we do, advocate for the patient and talk with the physician again about what the patient is saying and what we're seeing so that we cannot have a routine pain medication that's not necessary.
Great comment. Thank you for that. And I totally agree that exploring the reason for the patient declining or the resident declining pain medication. And I'm not even sure that in the scenario that was presented that you implied that the resident was declining as much as when you asked the resident, did they have pain, the answer was no. But nonetheless, we definitely want to make sure that we are keeping residents as comfortable as possible. And if there is a fear of addiction or a fear of overdosing or a fear of a negative side effect, we could explore that and educate them on that as well. But great comment. Thank you so much for your insight. Anything else out there? I was very excited to see how many people are using some sort of pain assessment tool in our cognitively impaired residents. That was very exciting and very positive. And for those who are not, the tool that's just one tool that's out there. And now you have it in your slides, and you may want to reference back to that and discuss that within your facility to see if it's something that your facility may want to embrace.
Again, if you do have a question or a comment, please press the number 7 or the letter Q on your telephone keypad.
We do have a question in the chat, and you can see that by clicking on the chat button on the top right. The question is, what type of interventions do you use to reduce or relieve pain? And the lines are open for any comments or responses to that question. Okay, Laura, do we have any other questions or comments on the line?
We do from Judy Ferguson's group once again. Judy Ferguson and group, please go ahead.
Okay, this question is in reference to the debridement. You have something on the webinar about moistening the dressing before removing it. Sometimes the doctor might order a wet to dry dressing for a very necrotic wound, and if we moisten it, doesn't that defeat the purpose of that? The reason why the doctor is ordering that, because oftentimes he said it will help remove the necrotic tissue when we are removing the dressing.
Yes, your description of a wet-to-dry dressing as a form of mechanical debridement is accurate. Some physicians will order a dressing to go in moist, wait till it dries out, and then they want you to remove it when it's dry so that necrotic tissue could adhere to that gauze and you'll pull it out. I just want to point out that for the last 7 years, I want to say, that form of mechanical debridement has been looked at and has been written about, and in the National Pressure Ulcer Advisory Panel guidelines is no longer an appropriate form of debridement. It is, number one, it is painful, and number two, it is what is called non-selective. That is that healthy tissue will also dry out, and you'll end up damaging any healthy tissue that may be in that wound bed as well, removing a dry dressing. So unfortunately, well, not unfortunately, but the fact of the matter is that wet to dry dressings as a form of mechanical debridement are no longer viewed as appropriate in the wound care world. So maybe what would be a good idea is to get your hands on a good journal article describing the other forms of debridement that are appropriate, or taking a look at the npuap.org website has the clinical practice guidelines on it related to the appropriate methods of debridement, and maybe your physician just needs a little bit of an update on new technologies associated with debridement. So pulling out a dry dressing will be painful. Moistening it ahead of time will defeat the purpose of mechanical debridement, but again, that form of debridement is in and of itself not appropriate. So that's how I would respond to that question. Does that make sense?
Thank you.
Ms. Harris, it appears at this time we have no further questions.
Okay, thank you. So if there are no further questions, then we will conclude the webinar. I'd like to ask Emily to please post the evaluation questions. And we would like to thank each of you for participating in today's webinar, and a very special thank you to Sue Crehan for her presentation, and also to our family caregiver for sharing her story. As a reminder, if you have not already registered for the VHQC online community, we encourage you to do so, and you can join that by clicking on the link that has been posted into chat. Please save the date for an upcoming webinar on medication management, regulations, and resident-centered care, which will be on December the 3rd from 2 to 3 in the afternoon. We are partnering with Maryland and Virginia Culture Change Coalitions to bring you this webinar, and we invite you to join us. The registration link was sent out last week, and reminders will be forthcoming. We hope that you can join us. Please take a moment to complete the evaluation questions before leaving. And again, thank you, and have a great afternoon.